good morning and warm welcome to Online Anaesthesia Postgraduate Teaching Program and Zoom platform, sponsored by Akrula and hosted by A1 Logics and aired by Anaesthesia TV. Today's session is dedicated to practitioners. The first topic is on minimum effective volume of local anesthetics for brachial plexus block. There are no definite guidelines regarding the volume of local anesthetics for brachial plexus block rather than the approach. So recently published articles have brought the volume from traditionally used 20 to 30 ml down to 2 ml per truck. Is it practically possible for practitioners? When we purchase a new car, the salesman says the car will give 25 km per liter under ideal testing condition, but we don't know what is that ideal testing condition. But it will give only 12 km per liter on road. Likewise, when they say 2 ml per truck, is it possible practically? They may have used a higher-end ultrasound with higher-end real-time images for doing the research. Can we replicate the same results in our practice with our conventional ultrasound? Is it a machine or the technique which is more important? Likewise, we have so many questions in our mind. To clear that, today we have Dr. Archana Apti, an expert on the subject. She is the right person to talk on this subject since she has published research article on dose finding study on brachial plexus. She is working as an associate professor in the Department of Anesthesiology in Mahatma Gandhi Medical College Research Institute, Pondicherry. If you are attending regional anesthesia workshop regularly, she needs no introduction. You might have known her competency and skills. She is a research scholar. She has published many research articles in the reputed national and international journals. She has received many national and international awards for regional anesthesia papers, not only for the regional anesthesia papers, but also for redefining the MD anesthesiology curriculum. She is a well-known faculty in regional anesthesia workshops and regional anesthesia CME and conferences. We are happy to welcome you to our online anesthesia platform, madam. At the end of the lecture, the questions will be discussed by Dr. Rajesh Jayaprakash. Over to you, madam.
Thank you very much, sir. Thank you for that wonderful introduction and for giving me the honor of being live on this platform, and also to precede one of my mentors, Dr. Bala Venkat, sir, whom one day I hope to live up to. Thank you very much. So with that introduction, I will get started. Sir, I'll be sharing my screen. Can you see my screen, sir?
Yes. You make it full screen.
I will make it, yes. Right. Okay. So a very good morning to one and all. And as sir has already told, my name is Dr. Archana Apti. I'm currently an associate professor at Mahatma Gandhi Medical College and Research Institute in Pondicherry. So today the topic has been given to me, that is the minimum effective local anesthetic volume for brachial plexus blocks. So as sir has rightly told in his introduction, yes, we do use a little low volume. And he said, no, madam, I don't want you to discuss in that way. I want you to please discuss it in the point and perspective of a freelance consultant anesthesiologist. So I hope that I can satisfactorily cover all the points and concepts that is behind this particular topic. And hopefully, maybe we can reach a little bit of a consensus together. So with that, I'll get into my topic proper. Right. So at the outset, I'd like to disclose that I have no conflict of interest with this topic. I have no disclosures to make. I have no particular preference when it comes to brachial plexus blocks. So when this topic was given to me, I don't know how many of you might be knowing about this particular scandal. But in our generation and the most recent times, this is one of those volume-related scandals that's been going on. So it's about Miss Elizabeth Holmes, who tried to create or try to assess or do 200 investigations based on one drop of blood. And she based an entire company on this, and she was the first and youngest female billionaire, self-made billionaire in Silicon Valley. However, now she has been turned out to be a fraud, and basically she has been taken to the court and she has been charged with a jail time. So hopefully our low volume problems are not so scandalous and so undesirable. So let's see where this journey will take us. right? So the outline of my presentation today, basically, I'll try to define basically what is the minimum effective local anesthesia volume. So the abbreviation is MILAV. That will be appearing in many of my slides. So I'll take you from where we started, the course through which we have traveled, and then where we are right now, and basically what is the discussion that is going on behind this particular issue. So when you look at it, what basically is a minimum effective local anesthetic dose? Basically, what is the ideal one that we want? We want some dose that is going to give us the perfect balance. It has to have the maximum possible benefits, almost should cover everything that we need, with the minimum or even no side effects is the best and most desirable. So we need a rapid onset. We should not have to be waiting for it. We should have a good potency block. We should have a nice analgesic action, and we should have no complications whatsoever. I think pretty much anyone can agree with me on this particular aspect. So where did we start out? Well, you can see that this is Winnie's first described publication that has been published in anesthesiology. This came out in the 1964. So this is when the subclavian perivascular technique, the very more genuinely known as the supraclavicular technique that we do today, this is the technique that the first description of it. So when I was reading it, actually, it was very surprising to me also that this is also the publication that this block is based upon the need to reduce the local anesthetic volume. Up until this point, people were only doing, let me show the next slide, they were doing axillary blocks. And the axillary based blocks, it was called as a axillary perivascular technique. And in that, they had given 50 ml of local anesthetic volume. They also noticed that only at that volume were they able to get the desired surgical anesthesia that they needed. So in a response to that, in order to reduce the need of the local anesthetic, they decided, that is Dr. Winnie, they put in 25 ml at the perivascular at the subclavian artery, and saw that you get a similar kind of an anesthesia effect, but your volume required is much less. So ladies and gentlemen, this looks to me like the first issue that is actually addressed the problem of volume. And it has arisen out of a need. Since then, there has been a huge movement, and it goes up and down, as you all have probably already known, right? So when we look at it, so what Winnie actually describes is only 25 ml, right? And it is very much dependent on the occurrence of a paresthesia. Only then he describes it as 98% success rate in his in the patients that he has performed the block in. He has used mepivacaine at the time because what his reasoning was is that it has a faster onset than lignocaine, but a little more longer duration of action, and that was more desirable at that time for them, right? They also stated that going above 25 ml of local anesthetic actually caused more of a cervical plexus blockade as well, since the facial planes are being shared together. So he says that if you need it only for your arm, you will only give 25 ml. That is the first described volume and technique. So as we move forward through the literature, you see the one, so basically in between the 1964 and 2003, I couldn't find very much articles that was describing these techniques. I mean, they were, but pretty much the volumes were standard. And there was no actually statement as to why the volumes were increased. Like from 25 ml of Winnie, it has almost gone up to 40 and sometimes 50 ml, but there was no actual basis or rationale behind why the volume had actually gone up so much, right? So when it comes to our technique, what we are familiar with today, right? That the first technique described was by Vincent Chan, that was in 2003. And this was the era where ultrasound was actually introduced. So once ultrasound was introduced, there were a lot more variations in the volume. Up until then, it was pretty standard, 20 to 40. But after this, there has been a drastic change and very significant going up and down. So let's take a look at that. So in 2003, Vincent Chan first described the supraclavicular approach, and he used a dual guidance approach. And he said that at least 40 ml is required to soak each and every individual element. Okay, then when you move down to 2009, so Tran Q et al. Actually have done quite a bit of work in this aspect. In 2009, they did an RCT that compared all three approaches, that is interscalene, supraclavicular, as well as the axillary approach. And in that, he stated 35 ml gave no significant difference in terms of outcomes. However, he also stated that higher volumes related to more complications and faster onset of complications. In 2009, Dugan et al., the supraclavicular, they did an up and down kind of a methodology where they determined that the lowest they can go is 19 and the highest they can go is 65. So they gave us an average of about 42 ml for a single point injection at the supraclavicular area. In 2011, Tran Q et al. Again reassessed the technique. And for the supraclavicular, it didn't really change much from 35 to 32. Again, this is also single point. As I move into the middle of my presentation, these terminologies will become more clear to you. For now, I'm just giving you a brief description about what the literature is just saying. So then in 2013 onwards, we've actually drastically come down on the volumes. So this one particular study told us it's around 0.95 ml. So he actually gave us a range between 0.5 to 1.2, but he has not actually assessed any outcome or whether the block is successful or not. He has spoken in terms of analgesia, and they had already given GA in any case. So it was difficult to actually decipher what his outcomes are. Then Song et al. In 2013, they came down to 17 ml. But at this time, the techniques were changing and it had turned into a multi-injection technique. So they've given at least 3 injections after identifying the different clusters and said that between 13 to 42 ml is what is the range they were able to use. So in 2016, now there was a meta-analysis with all the literature up until that time. And in that, so I have given you the QR code here. You can scan it for this article. It is a very good read. And basically, they had reviewed about 25 randomized controlled trials, and which had about 1,900 participants. And they basically overall reviewed all the techniques that were available till that time. They found that there is a 92% success rate when they were on average injecting about 20 to 35 ml of local anesthetic. So basically they stated anything more than that really didn't provide any additional benefit, unless it was in the axilla. And then there are also several studies now stating that, beyond 25 ml, really there is no added benefit or loss. Okay. So more recently now, let's coming up to 2018. Now we've come up to 15 ml. And in our institute, we have this publication where they have stated that where they can identify trunks and they individually block the trunks, then they are giving around a total volume of 10.5 ml. Okay, but that's of course divided between the individual trunks. So quite a variation in literature and quite a bit of fallacies actually. So why all of these fallacies and differences in opinion? Well, there are quite a lot of difference and variation in the study designs, right? The designs that they use, basically you use an up and down technique, you have smaller sample size, and then it is basically using statistics or a calculation to, apply it to a larger population set. So how applicable is that is one question. The second thing is none of these authors have used similar agents across their studies. Either they are using single agent, either they're using combination, or they are adding adjuvant. All of these cause manipulations and changes in combination in your local anesthetic or block outcomes. The next thing is the injection technique itself, whether they're doing 1 injection, 2 injections, or even more than 2 injections in some instances. The other major aspect also because of the intervention of the ultrasound, there are different endpoints that are also now described. There is periplexus, there is extrafacial, there is subfacial, There is interplexus, corner pocket injections, intracluster, and I'm sure there are a lot more terminologies that more of you are probably even more familiar with than I am. These are the ones that I found that are most common and used for describing brachial plexus technique. So all of these, when everything changes from study to study, how can we standardize it? How can we come to a conclusion? And that is why the literature is giving us such a huge variation in the answers. So that's about the literature. So I just did a little bit of a background homework just before I started preparing for my presentation. And I thought I'll go and ask real life people that I know, who I know are practicing regularly these blocks. So I just did a very general survey kind of, I just asked 2 questions to people whom I know, whom I'm in contact with, and basically looked for what answers they would give me. I thought maybe they would help me out with my PowerPoint a little bit. And they actually did. The answers that I found were very interesting. So most of it, I approached about 40 people. I know it is not representative of an entire practicing consultants, but let's just see what they have to say. So basically, the majority of the people are from India, but I also did include few of my contacts that I have around the world in Singapore, US, the West Indies, and also from Canada. In India, of course, these are basically I selected consultants who are regularly performing these blocks. They are ranging from junior to senior consultants. They're mostly in private practice. And so it's either corporate hospital practice or freelancing consultants. Very few are in an institute. And they basically, whatever is using any approach in combinations to whatever they have. So what are the questions that I asked? Basically, I purposefully asked them open-ended questions. So how much volume do you use for brachial plexus block? I did not specify which approach. I just wanted to see what they would say. And also when they selected that volume, why specifically are they using that volume? Whether it is how they were learned it or they have taught, whether it is they've gone through literature and then they have adjusted based on that, or whether it is from their own experience. So let's see what actually they had to say. So in about 38 consultants who responded, most of the consultants that I spoke to basically gave me that, okay, no, it's brachial plexus is too vast to tell, it's a single block. There's so many approaches. So which approach do you mean? So when that happened, so I was very enlightened by that answer. And then I was able to segregate based on the approaches. So the most common approaches are interscalene, supraclavicular, costoclavicular, and the axillary approach. So I have confined my findings to these 4 techniques. So when you see that in the interscalene, the variation is actually quite high. What was more surprising is that out of the 38 people that responded to me, I had 38 different answers to decipher. So my Excel sheet, what I had plotted or whatever I had to enter, it was quite varying. So it was very difficult actually to analyze these results. But I tried my best. And when I came down to it, basically for the interscalene, the very lowest end of it is 5 ml. And the very higher end of it is 30 ml. But the majority of consultants go within the range of 8 to 15 ml for interscalene approach. When it came to the supraclavicular approach, it moved up a little bit. So it was from about the lowest was 10 ml to the highest of 40 ml. And the maximum range of consultants using it in between 15 to 25 ml of local anesthetic, right? When it came to costoclavicular, actually very few consultants were doing the costoclavicular, but it was about 10 to 20 ml of local anesthetic. Axillary, actually even fewer still are using axillary block. And there the range goes to about 1 to 5 ml per nerve. So this is basically how they have been practicing. Most of them, I think out of the 38, only 5 are still sometimes do landmark as well and PNS guided blocks as well. But for the most majority part, they are doing ultrasound guided blocks. They could also not give me a consistent answer as to the LA that they were using. None of them were using similar combinations. So it ranges from either single anesthetic like ropivacaine or bupivacaine. Neither the concentrations were the same. So there was so much of variability, even in our own setup with our own patients. Different consultants have found different means of doing the block, but the blocks are getting done. Patient surgeries are getting done. So this is actually quite interesting to find out. They are, however, very universal on the fact that lower concentrations are good for analgesia, and we use higher concentration or higher volume for surgical anesthesia. So this is one point that was quite clear amongst all of them, and they consistently responded in that way. So when the question was, why do you use this local anesthetic volume, this specific volume? So the most common answers for those who are using higher volumes, like most of them, it was basically they did not want block failures. So you mostly were on either end of the spectrum of the experience of the consultants. So the very young consultants, as well as the over 15 years of experience consultants. So it's like I've got this way, I've been doing it this way, I haven't found a problem yet, so I have found no reason to change it. So the intermediate volume practitioners who are using that, basically most of them were ultrasound-based techniques, and basically they watch the ultrasound spread. That's why they have some variation. And also the other concept was, I'll give on the higher spectrum. If I'm not having a problem and there's no downside to it, what is a little extra volume actually going to lose out on? That was a very common comment that I received. And those who were practicing lower volumes, it is basically based on their own individual experiences when they're doing these blocks and watching outcomes of the patients, and also some of the literature review that is there available right now. So these were the most common answers that I received for the questions that I had asked. Now, how can we infer anything from these results? Right? They're quite variable. In terms of volume, in terms of technique of injection, in terms of type of local anesthetic, in terms of using an adjuvant or not using an adjuvant. So why is there so much of variability when it comes to this particular question? I mean, it's a simple question. It's something that we practice day in and day out, and still over the last 40 or so, 60 years, we're not able to reach a single conclusion with this. So basically, Thomas Jefferson said these famous words, it is that the difference of opinion can lead to an inquiry, and an inquiry to the truth. So let's see where the truth lies in all of these different answers. So basically, the minimum and local anesthetic concentration is based loosely on the pharmacological principle of minimum alveolar concentration. This is something we're all very familiar with. It's universal, it's accepted. You ask any single anesthesiologist in the world, and they will have one answer. Why? Because it's simply, there's one accepted definition, there is only one route of administration, there is a linear relationship with the concentration of agent. You increase the agent, you increase the MAC, you reduce the agent, you reduce the MAC. It's easy to administer, and also the outcome is just one. It is the response to the surgical incision that is accepted overall. So we titrated based on this. This is why this question is very easy to answer. But when you take in local anesthetic volume for block that has so many approaches, so many techniques, so many places to deposit, so many agents to use, and quite difficult and challenging techniques to use, let's look at all these factors now. So the first and foremost is the actual pharmacology. So these factors I'm going to describe in no particular order. I'm just going to describe them one at a time. So the very first and foremost one is the pharmacological variations. Now we all know different local anesthetics are different because they have different structures. Basically, the aromatic ring and the terminal amine are the same. The linkages are going to change, and the R, wherever you're seeing it, those chains are going to change. These inherently change the property of the local anesthetic, that is basically their potency and how they act. So the mechanism of action, we are all very, very, very familiar with the mechanism of action. The first and foremost thing is The local anesthetic acts at the sodium channel receptors. And at the sodium channel receptors, basically what happens, the local anesthetic crosses the cell membrane and then goes into the intracellular part and blocks the sodium channels from the inside. So all of these properties are dependent on the formation and the ionization of the local anesthetic. This is what is pH dependent, and also the lipid solubility plays an important role here as well. So at this point, this is the action of the drug. And in order to have a clinically effective neural blockade, we need to block 70% of these sodium channels that are present at the nodes of Ranvier, and we have to block 3 consecutive nodes of Ranvier, essentially to have a clinically effective blockade of a neurotransmission. This is this is based on the potency of the drug. This can be varied by the drug itself or even the concentration of the drug itself. So obviously, the more concentration you have, the more potent the drug is, the volume would hence come down based on that. Okay. But it is not just the potency or this pharmacological property of the drug. Local anesthetics actually need a volume or a physical property as well. Basically, one is the diffusion of it. The nerve, in order for the block to take a proper action, the local anesthetic has to be properly deposited. And once it is deposited, it will diffuse because of the axonal arrangement within the nerves and the plexuses. Basically, they have to, the local anesthetic has to diffuse from your point of deposition and reach the internal axons in order for you to get a complete conduction blockade. If this does not happen, this is also a common problem for us where you have partially acting blocks or sparing or whatever the problems that we face. Basically, your nerve block is not adequate. So this is also another factor in addition to the potency caused by the sodium blockade of channels, right? So volume and concentration. These are 2 separate individual properties that we need to take care of when we are performing a local anesthetic block. The other thing is, so this is about volume in the cross section. When you look at it in a longitudinal way or the spread wise, right? So circumferential spread is one thing. The next thing is in the nerve, when you're blocking at one area, how does the block impact the distal areas? So basically that is the mantle or the core effect. If I am giving local anesthetic volume right here at the proximal part, basically I am depending on diffusion to come across the nerve fibers. Only when the diffusion comes to the core or central part of the fibers will my distal end get blocked. This is termed as the mantle. This is the mantle arrangement of the nerve fiber itself. And this is also clinically impactful. So when you're using small volumes and your use of volume is limited to one single area, but still the block is distal, the block will still act. The only thing is it will take a longer duration of action because basically a longer onset, the drug has to diffuse across the membranes in order to get to the core in order for the block to take a full effect. Okay, so this is onset. On the other hand, if you are increasing the volume along the length of the fiber, what is going to happen? You have a lot more local anesthetic. You have a lot more length of nerve that is exposed to the same local anesthetic. And hence, clinically also, we do see similar outcomes where the onset is faster, it is more complete, and your wait time is more, and possibly your durations are also longer because of this particular aspect. Okay, so this is another point about volume of local anesthetic to be used. So what is the difference between the lower volume and what is the difference between the higher volume, right? So that is about the pharmacological, that is the aspect of the local anesthetic itself. Now, what are the other factors that can take place? Well, first of all, then there are the anatomical variations. No individual person is same to another person. Their own brachial plexus is their own, right? So we are operating basically in the 95th percentile, but there will be variations on either ends of the spectrum, right? So variations happen from patient to patient in the same individual. The nerve that comes out of the interscalene, what you're seeing there, is different from the nerve that you see in the axilla, even though it is the same brachial plexus. How does it change? There are quite a bit of studies in relation to this as well who have looked at it. In that, the more proximal you are, the lesser the connective tissue. So this is one of our studies that we did, a cadaver study that we did for the brachial plexus elements to actually see what is there in their formation above the clavicle. So when you look at it, you see the roots. The first three pictures are basically the roots coming in. So that's the C5, C6, and C7. And here there are all together in the interscalene groove. You see that they're hypoechoic, they're single, they appear to be single, they appear to be round. Now, I'm not saying there is no connective tissue at this point, but this is what our ultrasound allows us to detect at this point in time. As you go more and more distal, you see the amount of, that is why the description also changes from single hypoechoic round to multiple hyperechoic honeycomb structure. So the honeycomb, basically, because it is the axonal elements or the neural elements are these black parts, but there is a lot more connective tissue now that is formed. So this is basically a protective mechanism of the body, God-given human body, and where it serves as a protective feature or a protective barrier for our nerves. So this is essentially the barrier that we are trying to cross. So where you're giving, that is why even you can see from people's experience and the studies also, the interscalene requires less volume simply because it is having less, it requires less to be blocked. But as you go more and more distal, you see the nerves are going to have much more connective tissue, so much more barriers to local anesthetic, and therefore you need to give more volumes the more distal you go down. So this is one very important factor that contributes to variation in these volumes and outcomes. Okay. Also, the arrangement of the axons and the fascicles within the nerve itself, that also can change and alter the susceptibility of the nerve to local anesthetic blockade. Then basically physiological issues of the patient, the demographic and the patient's build itself can cause so many variations. This is one study that determined that age is a huge determinant factor in the volume that is required. So they state that not only in terms of anatomy, there are variations between the elderly and the average young adult, as well as the physiological susceptibility to the local anesthetic. So this is a very important point also to consider here. Other factors that can influence it is obesity and difficult anatomy. So these two factors, what usually happens is you don't increase the dose because of the body size. We are increasing the volume because the anatomy becomes, difficult. So in order to enhance our blockade and ensure there is proper blockade, we go ahead and we give a little bit of extra volume so that we make sure our blocks act, right? Apart from that, the genetic variabilities also can happen. So the genetics is very much important for the makeup of how we respond to local anesthetics. So even though overall we all do respond on a similar scale, there are minute differences that can happen, especially because of your genetic makeup. I mean, I'm sure a lot of you would have encountered this when we're giving spinal also. Sometimes, no matter how many times we give a spinal, it does not act. That is a basic fundamental. It is not always related to a technique. Sometimes it could be that the patient is resistant to the local anesthetic itself. And in that case, obviously, that would influence your outcomes that you need. So the next point to discuss is the techniques being adapted themselves by the practitioners and where the drug is being deposited. So you can actually, I observe that in all the results, the closer you are to the nerve, the lesser the volume that you need. So if you're like 1-2 centimeters away from it, obviously you need to give a little more because your intent is that you want the volume to go to the targets. But if you're at the target, obviously you are automatically going to reduce the volume of local anesthetic that you are going to supply. Next is the single injection versus multiple injections. So this is just a direct way, a more direct way of spreading the local anesthetic, if you must. Instead of waiting, giving it at one place and waiting for it to diffuse across and involve the entire plexus or the nerves, essentially practitioners, they just redirect a needle and then go from one identity. But the ultrasound, this becomes very easy since you can now identify each and every place and then go and do it. The other thing is also the brachial plexus sheath. This forms a very important anatomical landmark and barrier for us, especially for regional anesthesia. You're giving above the fascia. It actually, this is also another study from our institute that is there in RAPM. So which states that the onset times almost 75% less if you go below the sheath as opposed to giving above the sheath. So I guess it all depends on what you want from your block. And so the safety questions are what is coming into place right now. Since we are practicing it all now, hopefully we are working on it. Maybe in a couple of years' time, we might have a lot of data regarding the safety outcomes of all of these techniques. The last thing I wanted to discuss here is the block outcomes. Now, your volume of anesthetic is going to change based on what outcome you want, whether you want an anesthetic dose that is full muscle relaxation, or you want an analgesic dose to supplement your general anesthesia. Either way, the same volume and the same dose or the same concentration cannot be applied when your outcome is different. So some of them use, proximally, they will use a short-acting local anesthetic, distally use a long-acting analgesic so that you have motor-sparing analgesia. These are different concepts and different permutation and combinations that are being used in order to facilitate whatever is the outcome that you desire to have. So it becomes very important for us to understand all these functionings of the local anesthetic, the block action and the performance techniques of these specific individual techniques. And the more approaches we know, the better options we can give to our patients, especially the deserving patients who would really benefit from, blocks like these. So the major issue when you're having higher volumes is phrenic, especially when it's above the clavicle or any block surrounding the clavicle, is phrenic nerve palsy. This is one of the biggest obstacle and hindrance to us when we are performing these blocks, okay? When you're doing landmark guided blocks, yes, pneumothorax is another concern, but the talked about and the one that everyone is worried about. So what is the concern? So this is a study that I picked up from Edward sir, who I found they had compared 3 different volumes, and their results were similar to the literature that already I have described, where the higher the volumes, the faster the onset of the blockade, and also the lower the volumes, that is around 20 ml, I think he has concluded is a satisfactory for a block and has reduced impact on the diaphragm. We are also now conducting, so future research can also target these specific set of onsets, like which volume would cause the minimum amount of phrenic nerve paralysis. At this junction, I'd like to disclose right now that anything above the clavicle, so this is based on a few blocks that we have seen in the last couple of years, any block done above the clavicle or even around the clavicle, so this applies to costoclavicular as well, causes some amount of phrenic blockade. But what's the difference? The closer you are, the interscalene, it is 100%, the supraclavicular, it is about 50 to 65%, and with the costoclavicular, it's about 20 to 40% involvement of the phrenic nerve. The question here, however, is how much, how bad is it? So the interscalene, it's quite close, we all know the anatomy. So basically, higher volumes in the interscalene, you are going to cause invariably phrenic nerve outcome. Those susceptible patient might succumb to it. And when you're directly giving a local anesthetic on top of the nerve or very close to the nerve, you're not giving much time for the nerve to compensate for itself. When you give lower volume drugs at this point, or at least more away, the phrenic will still get blocked at a later time, maybe around 40 to 45 minutes. How it gets blocked is because the local anesthetic, the same way it diffuses into the core of the nerve, it is going to diffuse away from the nerve and anywhere. Basically, we have no control over where the diffusion happens. When it's happening in one direction, there is nothing to stop it from going in another direction. So, but this takes time and the involvement is more gradual. So it's compared to you suddenly walking up 5 stairs of steps or you gradually walking a floor at a step at a time. We can accustom ourselves. It'll take us longer, but we'll get there in the end. The same thing happens in the phrenic. The diffusion gives us some time or gives the phrenic nerve or the opposite side to get accustomed to it. And therefore, as of recent times, even with these volumes and the different techniques, we are actually seeing lower and lower incidence of phrenic nerve palsy. That being said, susceptible patients, you never know, anything might happen. So we still need to be very watchful and very careful on this particular aspect. So then with all these factors coming in, how can we arrive at any given answer? So where should our future, what should we be looking at? How can we go about investigating this? Well, you can tailor it to your own practices. You can basically define what is the outcome you need. My patients might, and my surgeons might require something different, which is what I have noticed in these 40 people that I have asked. Their outcomes, their requirements, their practice is much very different from mine. I mean, the basic fundamental is the same, but there are so many logistical things that happen that go back and forth. And also you need to standardize your technique, define it, and then apply it to that single set of population. It cannot be that one will fit all. It will never happen like that because everything is so different. So you need to investigate one outcome at a time. Also, try to avoid using adjuvants since we do not right now know what the adjuvant is actually doing. First of all, the local anesthetic action is so variable. So the adjuvant is plus or minus based on your own experience. I personally do not use adjuvants. I go on, if I want my block to be longer acting, I either go for catheter-based techniques or I will cover it up with the systemic regimens after I'm done. So we should move on from this concept of minimum effective local anesthetic volume to clinically effective local anesthetic volume. And if we have a range and if we have options, then I think that's a good enough way to go about it so that we are serving not just a single subset of population, but we are trying to address the entire population that presents to us for these particular surgeries. So I think that this is a much more logical way of looking at it rather than just getting someone's experience, someone else's volume and trying to apply it and make it fit. So you're making a square fit into a triangle. I don't think it works out like that. So this is probably a better approach in how to attain your goals in your practice and your setups. So basically, overall, if I wanted to consolidate it, when you have an ultrasonographic technique, and I know Sir also mentioned here that in your institute, you have an, higher end ultrasound, but I'm going to disclose that it's not available all the time. So we do have another ultrasound machine, and I also do go for private practice sometimes where I do share the machine with the radiologist. So even then, even if your machine is not good, it's all basically your training and what you know to look for it. So basically practice makes it perfect. If you keep on doing it, even if you have the ordinary ultrasound, so I know everyone cannot have the expert or the high-end machine, but even with the ordinary ultrasound, we can have these kind of results. It's just about how much we are going to get ourselves into the practice and to accept it. So from my consolidated literature search, from my experience, and also from my small survey that I had conducted, this is basically the volumes that I could basically summarize in terms of approaches. So for the interscalene, it is 3 to 5 per root, supraclavicular 5 to 7 per trunk, costoclavicular 5 to 7 per cord, and in the axillary, it is about 3 to 5 ml per nerve. Each volume has its own individual characteristics that we need to be aware of. And in ultrasound technique, we have to watch for the local anesthetic spread. That being said, now still quite a few, we are still using landmark and PNS guided techniques. So in this aspect, I could not find a lot of literature that, especially since ultrasound has been introduced. But from whatever is the literature and from whatever is the experience that I could gain from other practitioners, interscaling is about 15 to 20 ml. Very rarely people go below 15 ml. For the supraclavicular, it's about 25 to 35 ml, and the axillary, it's about 30 to 40 ml. And this is basically what I could find in the literature. When I did learn it in my post-graduation, I was also using more volume than this. So I think this one, summarizes or consolidates the 95% of practitioners' practice. But here, of course, you don't have anything. The objective endpoint is the paresthesia or, of course, the muscle response to your neurostimulation. So unless these are there, your block outcomes obviously will be very variable. But it's okay. Do not consider that your failure is because of your block. It could be also the various conditions that I have already described. So when going to try lower volumes or newer techniques, basically we are the advocate for our patients. We are stepping into an era where we can have open-ended and honest communications with our surgeons. Don't be afraid to try something, and failure is inevitable. It's like change. That change is the only constant. Similarly, failure is inevitable. Only when you fail, you will realize that, okay, this is possible, something to introspect, something maybe I can improve on. And that is the only way we can grow and progress. So this might not impact the majority of the population, but definitely in those deserving patients and the difficult population, these sort of concepts and thinking and logical combinations and techniques will actually make your practice much, much more worthwhile. And also the deserving patients who would really benefit from these sort of techniques can really, get a greater outcomes for them. So this is just one such patient that we had where he was a case of CKD. He was on dialysis. He has come from a nearby village, and he had a ruptured aneurysm of his AV fistula. As you can see here, it was quite, he'd already bled. He was in pulmonary edema. He's got tall T waves. His blood pressure is through the roof and all such problems. So, the usual accesses to brachial plexus here are gone. Since he is in CKD and a difficult airway on all of these things, this is just at the COVID time it was starting. So we're quite unsure about what's happening. And even then, so GA is again, a really scary technique to use. So here the question was, why couldn't we go axillary approach? We could have, but the minute we put the probe on the axilla, you can see here, actually, this is his cephalic vein. All of his veins are arterialized and they're distended and they're huge. So the picture was not any different than in the ultrasound, where the veins and arteries, there was too much vasculature and the nerves just could not be seen or accessed safely. So we did go ahead and we did a low volume. Yes, it took a lot of time for onset, but I think that amount of patience and attention is required, especially when patients like this appear to us, in order to preserve our practice. So I'm not advocating for low volumes, but at the same time, clinical effective volumes are the ones that we should be aiming for. And with this, I will open the floor for discussion. Thank you very much for your patient listening.
Thank you very much, madam. You wonderfully expressed that it is not the machine, it is the technique and the knowledge that is more important in reducing the local anesthetic dose. So over to you, Rajesh sir. Please take the.
Thank you, Dr. Archana. It is a wonderful lecture. We have some queries. You told that if you deposit the drug very close to the nerve, it can reduce the volume. So how close? How to make it as a safe, close contact with the nerve?
Okay, so different schools of thought here. So how close is, try not to get into the connective tissue or into the hypoechoic black areas. those represents the fascicles. So as of now, the advocated technique is to just get in the vicinity of it. So where we practice, what I like to do sometimes is just get to the white part of it. So that represents the subparaneural sheath or the outer epineurium. So that is one aspect. The other, so there when we go, yes, the 2 ml, 3 ml, what we're talking about, that will suffice there. But if you're coming just beyond it and you want to deposit around the nerve, then in that case, that's where you go up to about 3 to 5 ml more, ensuring that there is circumneural spread. That is, it spreads around the nerve. So, giving a better exposure for diffusion.
Okay, in that angle, do you think that addition of PNS, nerve stimulator, to your ultrasound technique, can it be more safe in reducing the volume?
From the studies, in aspect of literature and experience, there is no difference. Actually, the PNS added in the terms of brachial plexus, I'm saying. The not much volume difference is there, is what they have found. Even if it changes, it's maybe about 1 or 2 ml, which I don't know clinically how relevant that is. But no, the neurostimulation added to the ultrasound did not actually give much more benefit in terms of brachial plexus block.
Will the mixture of short-acting local anesthetic and long-acting local anesthetic will reduce the help in reduction in the volume?
Okay, so this is actually a very different, an entire topic on its own. Right now, it's an ongoing controversy. So I use a combination sometimes, and I use also single local anesthetic sometimes. But in terms of volume, that has not the type of local anesthetic has not affected my volume that I use. The volume that I use is the same. It is to the outcome that I change my anesthetic. For example, if I want a short duration, then I go for lignocaine. If I want a longer duration analgesic, I go for bupivacaine or a lower concentration. If I, that sort of thing. So that's how, but the volume actually does not change when I go for different local anesthetics.
Hello, sir. What's your take, sir? Is a combination or single planet?
Yeah. Good morning, Dr. Edward, and a lovely presentation, Dr. Archana. And whatever I speak now is something which I've gone through. This is my 27th year into regional anesthesia. Started with paresthesia technique, moved on to the peripheral nerve stimulator, and then moved on to ultrasound. So whatever I speak, and even the world, if we categorize now, I think ultrasound is accessible only to close to 10 to 15% of anesthesiologists in the developed nations. Forget the developing countries. Even in United States, I realized that several hospitals do not possess ultrasound even today. So whatever we speak should be something which is a take-home message for every single anesthetist who is a part of today's discussion. So when you get primarily the objective is regional anesthesia. Does it help the patient? Answer seems to be clear, yes. And it seems to be very important in low resource settings, even inside a country where there is not appropriate high dependency unit, one-to-one nursing, monitors available to all the patients. So it becomes pertinent that based upon the infrastructure with which you're working, you need to choose the technique and the technology. So, and the regional block has to work. Now, I completely agree with Archana on going to lower volumes with the help of ultrasound, placing the drug subparaneuronally, which is a good pathway. It's called the new highway of placing the drug, and with a minimal volume, trying to get an effective block. This is one end of the spectrum. But then, if you consider it completely as a whole, for all those people who don't have ultrasound, or those who have never used ultrasound but still wanted to do regional block and make it effective, either with paresthesia technique or with a peripheral nerve stimulator. My having used all the three, like for several years, I could say that, and also based on the current literature, like my take on this is step number one. When I decide to give a block, this block has to work. Step number two, by giving a larger volume, am I producing more catastrophic results to the patient? The answer seems to be no. The reason is, if you look at the chapter in Admir Hadzik on the rate of absorption of the drug from various parts of the body, it is very clear that if the epidural absorption of the drug is much more, intrapleural absorption from the where you deposited the local anesthetic going into the system is much more, but not the same where you place it in the between the epimysium and paraneurium or between paraneurium and epineurium. It is not the same. So majority of the studies which have been conducted, which decided about the toxic dose of the drug as 6 milligram per kg body weight, 4 milligram per kg body weight, and 2 milligram per kg body weight, all these studies were based upon human volunteer studies where the drug was placed in the epidural space and plasma levels were taken. And they came to this kind of a conclusion of this milligram per kg body weight of bupivacaine. And so it was all based upon one particular placement of the drug in a tissue and seeing the plasma level. Same is not true for brachial plexus, where the rate of absorption is not equal to that of epidural. In other words, my take is, in a controlled atmosphere in the presence of an anesthesiologist doing a block, who knows how to treat a local anesthetic toxicity, my game plan will be to make the block work. Even if I'm going to give more volume, I want to make the block work. That's number one. Number two, when you use a peripheral nerve stimulator or when you are using a paresthesia technique, Dr. Rajesh, I would prefer to go for a combination of lignocaine adrenaline with bupivacaine for more than one reason. Lignocaine adrenaline comes as a preformed drug in a vial where each ml contains 5 micrograms. And when you are the lone anesthetist, if you use a combination, if you decide that I want to use a peripheral nerve stimulator and give a subclavian perivascular approach block, and we decide that my volume is 25 ml, I just wanted a combination of 10 ml of lignocaine adrenaline and 15 ml of bupivacaine for only one reason. In spite of negative aspiration, not knowing where the tip is, many times you see the drug going intravascular absorption. So when I add lignocaine with adrenaline, this gives me a marker for inadvertent intravascular absorption of the drug. It becomes very pertinent in extremes of age group, the pediatrics and the geriatrics, where the connective tissue around the nerve is very, very less. And I found that these are the very vulnerable categories. So what I was teaching before ultrasound came, when PNS was to be used, that when you do a block, you need to meditate. First, you have to see the heart rate. Suppose it is 80. I tell them connect the pulse oximeter, have the intravenous access, and now 1 year is completely dedicated to the heart rate. If you see suddenly the heartbeat going more than 15 beats per minute when the drug is being given, then in spite of negative aspiration, until proved otherwise, this is going intravascular. So for safety reasons, when you are alone, as a kind of a marker, I would suggest a combination of lignocaine adrenaline with bupivacaine.
Interesting opinion, sir. Jayprakash sir, any more questions, sir?
Sir, only your question is remaining, sir. Even after getting a good circumferential spread, sometimes we get failed blocks. Is there any specific reason where we are missing the link? Dr. Archana, is it?
So can you repeat the question, sir?
No, the volume, so related to the volume, if you aim at circumferential spread of to the nerve, sometimes we do get failed block even after getting circumferential spread. So do we have to increase the volume there, or something else has to be done? Where are we missing the link there?
Yeah, so that depends on the situation, and which block you're doing. So mostly, even if you give a circumferential spread and you get a partially acting block, then the option is, yes, you can go ahead and give an additional one, maybe distal to it, to enhance the blockade. Or you could supplement. You can increase the volume of local anesthetic, but obviously by the time you recognize it, you would have taken out your needle. So that's a very tricky situation depending on what you're looking at. You can also always supplement it with systemic analgesic, and hope that takes care of the gap.
Can I add for this, Archana?
Please, sir.
See, actually, I think we are slowly moving towards every surgical procedure has to be individually conceived, and it's mathematics. So you need to deal, it's just not what we have been thinking about humerus fracture. It's not like that. So we need to think whether it is a proximal humerus, midshaft humerus, or lower third humerus. Then you need to define the dermatome, myotome, and osteotome that needs to be blocked. And also, so which means you're going to choose the technique based on where you're going to, what is the requirement of your surgeon. And one thing which we need to remember is the plexus can get prefixed and postfixed. And many times we have seen for the lower humerus elbow surgery, you gave an excellent, as you rightly said, the drug spread was superb, and the patient was not able to lift the hand. So myotome is completely gone. And now you position the patient laterally, and you're going to make an incision in the posterior surface of the elbow, and patient shouts. And now the data clearly shows that the dermatome is supplied by C3-C4. So it is prefixed brachial plexus. And this happens very often. So C5 was blocked, but C3-C4, the drug didn't reach. So and it's not under your purview. So you do not know which plexus is prefixed or postfixed, and what are the contribution of a particular dermatome from where it is coming from. So this is something which you need to keep in mind, that it's beyond you, that there has been a contribution from different levels. And that's why, in spite of you blocking the C5 excellently, C6 excellently, your block didn't work, because it's just not the volume, but it's the neural components which are coming from the other twigs.
Thank you, sir.
One last question from Dr. Vipin Goyal, sir. Will the low volume blocks, will it affect the duration of analgesia in the post-operative period? The low volume blocks, Dr. Archana.
I didn't hear your question, sir.
Will the low volume blocks will affect the duration of analgesia when you go for low volume blocks?
Yes, in my experience, it does affect the duration of analgesia. Obviously, the lower volume low volume has a more onset, and also the duration is reduced. How much it's reduced, again, it goes from patient to patient and block to block. So that can't standardly tell you what it is, but hopefully in the future, with the few studies that we have coming out, we might be able to answer that question shortly.
Thank you, madam. Thank you. Thanks a lot. I think we will move ahead with the next session.
Yes, sir. Thank you very much, Rajesh, sir. So we next come to the second topic, is current concepts and future trends in ultrasound guided regional anesthesia. In those days, there is, 30 years back, when we were performing the landmark guided blind technique, the errors were more, so as the complications, and the success rate was less. But now, after the introduction of ultrasound blocks, the complications are less and success rate is more. So what will be the future? Are we moving the right direction towards the zero error nerve blocks and 100% success rate? To clear that, we have the pioneer in the field of regional anesthesia, Dr. Balavenkat sir, in our platform today. He needs no introduction. His name itself speaks. He is immediate past president of Asian Oceanic Society of Regional Anesthesia, educational committee member of World Federation of Society of Anesthesiologists 2020 to 2024. And he is the national chairman of Academy of Regional Anesthesia of India. He is an associate editor of Journal of Regional Anesthesia and Pain Medicine. He is the governing council member of Indian Society of Anesthesiologists. He is the section editor of Regional Anesthesia in the Indian Journal of Anesthesia. He is the editorial board member of Journal of Research Society of Anesthesia and Clinical Pharmacology. He is the course director of Askila Academy Ganga Hospital Regional Anesthesia Guidance Center and World Federation of Society of Anesthesiologists and Ganga Hospital Regional Anesthesia Fellowship. And he is the course director of postdoctoral fellowship in nerve block and pain management of Dr. MGR University. And his academic achievements are much more, which is difficult to enumerate all here. We are immensely pleased to welcome you to our online anesthesia platform, madam. Sir, thank you. Over to you, sir.
Yeah.
Over to you, Bala, sir.
Yeah, thank you so much, sir. I'm just sharing opening my slide. So can you see this?
Slide is not visible, sir.
1 minute. Can you see it, sir? So can you see my slides?
No, sir. Sir.
1 minute, I think. I'm 1 minute. My Zoom link is yeah, let's see.
So now it's visible.
Is it visible, sir?
Yes, sir. Now it's visible.
Yeah, audio is okay?
Okay, sir. Fine. Sir.
Yeah. So immense pleasure to be a part of this learning platform. And I would like to heartily congratulate Dr. Edward Johnson and Dr. Rajesh for moderating the session and all the associate editors of this platform. And I think it's very, very crucial and important that every anesthesiologist empowers himself with the new updated developments in technique, technology, and the evidence-based medicine, which has become easier nowadays because of the virtual platform. And this in turn results in empowering you to treat critically ill patients with very good outcome. And the morbidity and the mortality can be considerably reduced when we keep growing and progressing in what we do. And thank you so much, Edward sir, for making this possible to people from all walks of life. They just have to be interested to invest time, and then they get what's the best that's going on in this world, so that they can directly pass this benefit to the patient. And I also firmly believe that when I was studying, my teachers used to tell, knowledge is power. And that power results in preventing death. So each one of us as anesthesiologists has the power to prevent death, provided we accumulate that power within us And what the mind does not know, the eyes does not see. So the learning platform like this enriches our mind, makes us learn new things, which empowers us to contribute phenomenally to our patient. And always I have found that I would start my presentation with some quotes which have completely changed my viewpoints in life. And you may have been born to an illiterate parent, but you can die as a scholar. So you can be a misfit during your childhood, but you can become role model to the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be. And I just want every single postgraduate to believe in their inner potential and to grow beyond their own goal setting and become one of the legends in the field. And for this to happen, we need to ask ourselves, my future comes from where my time goes. So where should my time go? For everything that you want to do, you need to have the time. In a sense, we reach a point in life when time almost becomes our God. So I want all the young postgraduates who are part of this session to channelize their time to equip themselves and just not passing the exam, because which is the smallest thing, but passing the true exam of life in becoming the most respected, revered anesthesiologist to a patient and a surgeon. I bring to you greetings from the city of Coimbatore, which has become extremely popular across the globe because of Adiyogi. And I bring to you greetings from Ganga Medical Center and Hospital, where I've been, this is my 27th year here. And we graduated from 2 operating theaters when I joined in 1995 to 38 operating theaters now. We were 3 anesthesiologists when I joined, and now we are 84 anesthesiologists. And we were operating about 14 cases when I joined per day, and now we have gone up to 125 cases per day. And also, I'm very happy that for the last 20 years, we effectively weaned off all the physicians from the hospital, and the entire perioperative care is looked after by the anesthesiologist. And hence, the use of ultrasound has become very, very handy, not only in giving nerve block, but also in vascular access, getting the venous access, the arterial access, point of care ultrasound in getting echoes, EFAST, lung ultrasound. So everything has become an inherent component, and the anesthesiologists play the key role. And this has helped us to save several lives. When a polytrauma victim comes, the resuscitation process, the team leader is the anesthetist, and they don't wait for the radiologist. The anesthesia team perform the EFAST, and if they see an intra-abdominal bleeding, they go for explorative laparotomy within seconds without waiting for other experts to come. So the contention and the notion of the use of ultrasound depends upon the ability to use it, availability of it in the institution, and getting a free hand to it. And when we started, we had no ultrasound, and now we graduated to PNS, and then we came to ultrasound. And now I'm happy to say we have 14 ultrasound machines inside the hospital available in every nook and corner. And a patient who comes into the hospital with a trauma, on arrival block has become a norm, whether it's day or whether it is night. And I think this has completely changed the way the patients look at when they come to our institution. And I feel this contribution by the Department of Anesthesia in trauma care is possibly one reason that more patients are coming here, because they know the minute they come in, they are made pain-free. And I thank our entire team, my team of consultant anesthesiologists, who have immensely contributed to the growth of regional anesthesia in our center. Many of them have completed their fellowship and joined here. They've completed their EDRA, they completed some of them IDRA. So they completely invest themselves to learn more about regional anesthesia. And I think we are truly a sacred branch, and we are the true angels, and very, very important that we take care of the pain of our patient. And I think when the patient comes in, we need to think the end in mind, in that this patient has to walk out of the hospital. And to become proficient in regional anesthesia, especially for all of us who did not know ultrasound when we were postgraduates, we were not taught about this, and we need to learn by ourselves. So how can we do it? Like, is it that since we were deprived during learning, do we completely remain a novice throughout, or can we graduate ourselves? The answer seems to be yes. This is like peak performers. Like, for example, this is an example which I've told myself several times in my younger age. Vishwanathan Anand plays his opponent at least 5 times to 10 times mentally before he meets them physically the next day when he goes for a world championship, which means every single move that the opponent will make and what move he will make. So mentally, he has played the game with his opponent 5 to 10 times before he goes into the match. Similarly, as a regional anesthetist, to be very effective, if you go and watch the Google, completely see which blocks, suppose tomorrow you want to do an interscalene block and you have not been taught professionally in that. So you go and see these videos again and again and again. Believe me, when you really go and put the probe, you will see the structures well. So you need to do that mentally before physically doing it the next day. And we need to have very, very strong work ethics. And we need to exceed our expectations when we combine our skill with the knowledge, with complete integrity and honesty to your patient, with absolute humility. You become an excellent anesthesiologist and superb regional anesthesiologist. Now, if you want to get your block right, whether you're using ultrasound or a peripheral nerve stimulator or even a landmark technique, what is that is required? All that is required is the nerve to the needle tip distance should be very minimal. We need to use the effective minimal dose of local anesthetic as it was discussed by Dr. Archana, and in the process not to harm the patient by producing a nerve injury. When you do this and you get your block right, believe me, you become so confident internally. When your block works, you are the most happiest person on earth. And you become a versatile anesthetist. Your self-pride increases. You raise in your own eyes, and you respect you earn from your staff nurses, from your surgeon, and from your patient. So it becomes very pertinent to get your regional block right. And the current path are either you use, I would not recommend anymore the landmark technique because of several reasons, that you don't have a clear endpoint and the failure rate can be high. And when you have a failure rate very high, your surgeon will not believe you. Your patient is under distress, and you yourself are going down your confidence level by giving repeated failed blocks. So it becomes important to gain a complete mastery over this, and minimum you should have is a nerve stimulator. And thanks to the advent of ultrasound, the last two decades has revolutionized the practice of anesthesia. And in doubt, in the early phases, or when you're doing a very important VIP person, or when you're doing very deeper blocks like lumbar plexus, it's a great idea to use dual guidance, where you use the ultrasound machine and also use a peripheral nerve stimulator to stimulate the structure which you think that it is a nerve with a very low current of 0.5 milliamps, see the desired evoked motor response, and then you administer the drug. So I think these are only the 3 pathways that are available for anesthesiologists to produce a very effective block. And before going into ultrasound, I think it's very important that you need to be very calm and composed. I think this is such an important thing in regional anesthesia, because the patient is completely hearing whatever you do and seeing whatever you do. Since we have been a training institute for regional anesthetists in ultrasound guided blocks, I wanted to use this slide because you know what? When you're doing the block, you shouldn't make like, oh my God, all these small statements that you make produces a huge impact on your patients. And since the current perspectives we need to discuss, I want to also go into human factors that are involved when doing a block. So my request is, when you decide to do a block, you should be very calm and composed, and you need to create, I call it as a block environment, so which has to be very conducive, and you should be in constant conversation with the patient, especially when you administer the drug, to make sure that the level of consciousness is maintained. And only in anxious patient use anxiolytics. Don't use midazolam or like fentanyl or propofol for every single patient. I would wanted to pass the benefit of regional anesthesia to my patient. So I want him to be awake. I want him to walk to the restroom immediately after the block. I want him to eat immediately after the surgery is getting done, which the regional anesthesia offers all these benefits. And this is negated if you start giving all the patients anxiolytics without they asking for it as a reflex. And it also produces nausea, vomiting, and then you need to give drugs for that. I one for one prefer a pure form of regional anesthesia, has to be tailor-made, and you shouldn't be engaged in polypharmacy, doing multiple drugs for your patients. So this is something which I strongly feel when you do regional anesthesia. And it's also very important to know medication errors are very, very common and a lot of reported literature. So when you load the drug, you need to label it. And I'm going to speak about the injection pressure monitor a bit later, but it's a miracle. Regional anesthesia is a miracle. And this is one common story which I tell. So this is Mr. Anand Peter. I got permission from him. He's the owner of Video Line. He's the #1 company which do live transmissions of surgical procedures and nerve blocks. So in major conferences where live workshops are there across India, he is there. So a couple of years ago, we have to start the arthroscopy live workshop at 9 o'clock. He was climbing the stairs. He fell down and sustained a wrist fracture. This was at 8:20, and 9 we have to go live. So immediately he came to the operating room with writhing pain. So we went ahead with the subclavian perivascular block. Of course, we used very minimal volume, like what Archana said, good drug spread. 15 minutes, 8:35 to 8:40, the block had taken very well. Dr. Rajshekharan, you see here, did the close reduction, pinning, and he was put on a slab. You still see the intracat, but believe me, at 9 o'clock sharp, he was there to do the live workshop. This is the magic and the power of doing an effective regional anesthetic procedure. And that evening, he went home as if he didn't have anything. And we informed his wife later that he underwent a procedure. So this could be the power of regional anesthesia. And also several times we have seen very complicated cases like patients with, this was a patient with ankle dislocation coming with 220/120, a plasma blood sugar of 324, heart rate 124 per minute, EF of 42%. So in this situation, either you can call for a cardiology opinion, endocrine opinion, and you can cancel the case. But also you are empowered with the new technique and technology that you explain the risk to the patient. He was also on dual antiplatelet. He was a triple vessel disease and he was advised CABG, which he didn't undergo. And he was also a case of DVT. So he was getting clopidogrel, he was getting aspirin, and he was also on warfarin. And now he comes with this. So we explained to the relative, to the surgical team, and all that we did was we went ahead and did a superficial block, where the vessel could be compressed. We went for the popliteal area, blocking the common peroneal and the tibial nerve in the popliteal region under vision carefully. And believe me, it needed about 20 ml of local anesthetic solution. And 20 minutes later, you saw a very pain-free patient, and more importantly, his pressures had come down to 140/80, heart rate had come to around 90, and we went to do a close reduction because it was grossly swollen. And 48 hours later, we again took him with a similar peripheral nerve block for surgical anesthesia, and then did the ankle fixation under pure block. So the point I want to convey is, once you are equipped with a tool like this, you can extrapolate it and use it to the benefit of the patient rather than asking for too many opinions. And in other words, you become so empowered that you yourself become the complete perioperative physician. And later you can get opinions, but then in an emergency, you did what needs to be done. So this was the mother of an anesthetist, 82 years old female. She had a fractured T11 vertebral body with severe pseudoarthrosis. The basic problem was her pulmonary pressures were about 85. So she was denied a surgery everywhere. And when she came and got admitted nearly after 2 months, it was mainly they came because of severe pain, which was secondary to the pseudoarthrosis, which developed after the fracture. So all that we need to do is, the surgeon said he wanted to do a vertebroplasty, and this patient underwent this the next day itself with bilateral erector spinae block, and under no sedation, the vertebroplasty was done and discharged home the next day. So all this completely shows that it is important that every single anesthetist in this country and in this world have to embark on a journey of developing the new skill. And I think this is the current concept. And as I said, on arrival blocks, on every single patient, you see the macerated monomilic polytrauma of this patient, but just see how quiet he is. And that small tool there, the ultrasound machine, can convert him to absolute comfort. And we use this very effectively for both preoperative, intraoperative, and postoperative. So this is something I wanted to say. Ultrasound machine has become the third eye for anesthesiologists, and it has to be used perioperatively. And rapidly, it's becoming the gold standard. Ultrasound machine has become the gold standard. And I think this has markedly changed the way we practice anesthesia. So it hastens the onset of the block. It decreases the total volume that is needed to produce a very effective block, but also need to consider that more and more the volume that you reduce, the duration of the block also becomes less, and in the process prevent a vascular injury, and you decrease the incidence of nerve injury. Now, there are many ways of doing it, like either you can do the needle. Once you've seen the sonoanatomy, you can go either in plane or out of plane. So I would strongly recommend for superficial blocks, for a beginner, it's best to go in plane rather than going out of plane, because they may not see the needle completely. So in the current context, I would strongly recommend that in plane would be preferable for those who are beginning. And the next thing is, all that you need to know is you need to track the needle throughout. And this is possible with repeated practices. And also, I would like all the institutions to buy a Blue Phantom. All the government institutions and institutions which are teaching postgraduates should buy Blue Phantom. And we need to, the needling technique. So getting the sonoanatomy right is step number one. But passing the needle towards the targeted tissue, targeted nerve is the most important thing. And to develop this skill, we need to use Blue Phantoms, and which is available in this country. It costs about 90,000, and all the departments have to invest on the Blue Phantom, and to make sure that the needling technique becomes perfect and the student is able to see the needle the entire course. Now, next, also to teach them whether to be very aggressive, like what you see in the picture on the left, where the tip of the needle is pretty close to the neural tissue, or teach them to be slightly away. Now, will there be a difference? The answer is yes. The rate of onset of the block will be much faster if you're very close to the nerve. But if you keep it slightly away from the nerve, then the rate of onset of the block will take a longer time, but it will still be effective. Now, in the initial phases, I think I would like to probably recommend that you need to be in the conservative approach. But when you become a master, where you can see the tip of the needle very well, either because your machine was good, your technique was good, or you're using an echogenic needle, which have become very popular now. When you see the tip very well, then you can slowly convert yourself from conservative to aggressive. And this is a schematic diagram which explains to you what happens if you don't see the tip of the needle. Then you can possibly pierce the, if you see, I've depicted a nerve fiber, and this is a single fascicle and this is a nerve fiber, and you may penetrate the epineurium and you may deposit the drug inside. And the problem is, not necessarily you will go and hit the fascicle and produce a direct neural trauma, but when you inject the drug in the interfascicular area, you're increasing the pressure in the closed compartment, which results in the occlusion of the vascular supply to the fascicles, resulting in an ischemic neuropathy rather than a needle-induced injury. So this is something I just wanted to convey to all of you. So this is a great recommendation to show that it's very, very important that ultrasound has become. And the complications are, it could be needle related, as I was discussing, it could be drug related, or it could be catheter related when you start using catheters. And in catheter related, the most important thing is infection, inadvertent migration of the tip of the catheter, or kinking of the catheter. In this country, I think at this point of time, very few centers are using the catheters. Many people use adjuvants. I'm going to speak about it. Archana was in her talk said that she is not using adjuvants, but I'm going to comment on our experiences. We use adjuvant and prolong the duration of analgesia. And in the drug-related, most important thing is the local anesthetic systemic toxicity. And current thinking is you need to monitor the patient after you give a block. You need to monitor the patient at least for 30 minutes, because after administering the drug, suddenly the rate of absorption can increase, and a local anesthetic systemic toxicity can happen even after 30 minutes. And in literature, it is reported up to 1 hour. Ideally, so the patient has to be under monitor for 1 hour for possible local anesthetic systemic toxicity, especially when you used a larger volume and in the extremes of age like pediatrics and geriatrics. And injection pressure monitors have come into vogue, and it's currently available in India as well. And the one which you see, the B-Smart, this is produced by B-Braun, and this conveys the pressure, what is happening in the tip of the needle that you see here, less than 15 psi, between 15 to 20 psi, and more than 20 psi. So when it is in the wide zone, you are safe, you can inject. But when it goes more than 15 psi, possibly the tip of the needle is intraneuronal and you should avoid. But there is an improvisation of this, and this is called the nerve guard. This is produced by the company Payang. So you can be a novice, but if you use this, like the syringe is connected to the nerve guard, and inadvertently, if you don't see the tip of your needle, because you're a beginner, you're not able to see it, you just push the needle inside. But inadvertently, if the tip of the needle is inside, it pierces the epineurium and it's inside, the pressure goes up, so you can't inject the needle. I mean, you can't inject the drug. The nerve guard closes it. So this prevents the drug from getting deposited intraneuronally. This is an excellent addition to the armamentarium of equipments in the current practice of regional anesthesia. So the local anesthetic systemic toxicity, as I spoke, happens either because of excessive dose or rapid systemic absorption when it is deposited in a vascular area, or accidental intravascular injection. And every single unit which does a regional anesthetic procedure should have intralipid with them. And the one which we have currently available with us is from Celipid, it's from Claris. And I would wanted Fresenius Kabi also has it. Both are available in this country, and every department should possess one. And also, I would want you to take the guideline of local anesthetic systemic toxicity, a printout of this, and to be posted in the block area. So every single individual knows how much milligram to give. And also very important that every single anesthetist should know where this intralipid is stored. If there is an emergency cart, it has to be a part of it. These are some very important things because you may have the drug, but the person should know where the drug is kept. And there are multiple mechanisms which has been suggested in how the intralipid results in preventing further complications, both cardiovascular and the neurological complications associated with the local anesthetic solution. Next, as we grow, we start thinking about other things. The ergonomics when you do the block. And I wanted all the youngsters to go through this. This is one important concept when you administer a block. If you see on the left side, wrist flexion, wrist extension, and the way the head is held, neck extension, trunk torsion, and trunk flexion. These are all not the ways that you should do the block. You need to evolve, and then you need to place the USG machine exactly opposite to you. You don't, in other words, have to have a neutral position where none of the part of your body is under stress. And you should be in a position to do the block without that. This is very important because if some part of your body is under stress, some musculature under stress, you may have gone in the right direction, but after some time you have that fatigue and you may inadvertently puncture the nerve. So ergonomics is very important. As I was discussing with you, it is also very, very important to know which block that you will choose and based upon the surgery. As I said, the myotome, osteotome, and the dermatome, you need to calculate and write in a paper based on the surgical steps, then you will decide on which block that you use. So it's important that you need to go through the dermatomes, myotomes, and the osteotomes. And actually, next important thing is when you were doing with a landmark guided block, you were always based upon drawing lines like this, and we didn't have a clue. We did not know whether there is anatomical abnormalities, but all this has been taken care of with the advent of ultrasound. You can see every single structure, you know every single aberrant vessel that is coming in, and you really become a master. So anatomy, sonoanatomy will help you to grow immensely in your future. And now from the nerve block, what is interesting, the current concept is interfacial plane blocks, where you deposit the drug between the fascias. And this has become a huge component of modern anesthetic practice, both in truncal blocks and in abdomen blocks. So for breast surgeries, it is the PEG block, the SAB block, it's the serratus anterior plane block, and laparotomies, it is the quadratus lumborum block, the transversus abdominis, the TAB block, and transversalis fascia block, erector spinae block for spine. So there are immense interfacial blocks which has come into vogue and has completely revolutionized the practice of regional anesthesia. In fact, the cardiac anesthetists were thinking that they wanted echo only for the transesophageal echo and transthoracic echo. And across the world, a new movement has started now in going for parasternal blocks for sternotomy incision and fast tracking the patient. This has become one very important step in open heart surgeries, and the sternotomy pain has been taken care by parasternal block. And the interfacial plane block has a lot of people questioned it, whether it is very effective, because when you go for a nerve block, you know that you're depositing the drug around the nerve. You see the circumferential spread of the drug around the nerve. But in an interfacial plane block, you don't see the nerve. You just need to place the drug between two fascias. And does it work? The answer seems to be yes. And it is driven, if you place the drug between the two fascia and a larger volume, this drug dissipates both macroscopically like a bulk flow or a mass flow and goes and hits the nerves which pierce the fascia. And also it has got a microscopic movement. And the spread depends upon the pressure gradient in which the drug was put between the two fascias, the velocity, the direction of the injection, the recoil of the distended facial plane, the sliding movement of the facial layers, and the movement that happened because of every single respiration. There is a movement of the drug. So this is an excellent article on the essentials of our current understanding of abdominal wall blocks, and it describes a lot of mechanisms on how effective the interfacial plane block is. So one of the things that we need to do is, apart from the cadaveric dissections, to view some beautiful picture schematic diagrams like this, the anatomy of this, and then when you start doing the block, then you will know this the sonoanatomy pretty well. So you see, when you want to do an abdomen compartment block, it's important to see the 3 muscles of the anterior abdominal wall. And then when you track, then you will actually, I will come and show the sonoanatomy, the quadratus lumborum muscle, the psoas muscle, and the erector spinae muscle. So the advent of ultrasound has, even simple blocks have become excellent for a laparotomy incision. And for example, an incisional hernia, it's important to go for the rectus sheath block. You just have to place the drug here. See how beautifully you can see. And this is C1 do 1 block. You need not undergo big training to do this block done. So you see that's the linea alba, and there's the rectus on either side, and you place the drug here between the muscle and the posterior rectus sheath. So this is the TAMP block, again very effective in part of a multimodal analgesia, provided you know how to place the drug. And you see a classic TAMP block being given. So you know that, yes, so you see the external oblique, internal oblique, and the transverse abdominis. This is the neurovascular plane. You can actually bring and in plane and come and place the drug here and open up this space and give a volume of about 20 ml. It works extremely well. So I think we need to graduate ourselves into start using this interfacial plane blocks. And it is also said that the anterior QL has emerged as a very important component of laparotomies. Bilateral the anterior QL blocks placed anterior to the QL muscles have found to be very effective in laparotomies. So this is something which I just want to show you that this is a very important sonoanatomy. You see the 3 abdominal muscles coming to an end. That's the QL, and this is the thumbs up sign. This is the vertebral body of the spine, the transverse process. This is posterior, the erector spinae. This is the psoas major, and this is the quadratus lumborum. So it is very, very effective when we do an anterior QL, place the drug here. And the advantage seems to be, apart from the somatic component, it also spreads to the paravertebral area, and the visceral component also gets blocked. That is why the anterior QL seems to be more effective than the other QLs in laparotomy surgeries. So when you go for knee surgeries, we can define now, we have to block prepatellar, subsartorial, and popliteal plexus. And you have so many options available when you go for knee surgeries. This has been the growth of regional anesthesia. The advancement in the technology and the technique and our understanding based on the cadaveric studies and the drug spread, many blocks have emerged. And this is something which is very fascinating. From the femoral block up to the lower part of the adductor canal, this is the sonoanatomy. And based upon where you keep your probe, you can see different structures. And we have designed in our hospital, we go for the dual subsartorial plexus block. This is based upon the studies here. When you placed in the distal adductor canal, you'll see the drug spreading to the posterior tibial plexus. So you are approaching the parts of the sacral distribution through the anterior approach. So this is something which we routinely do, and we find it extremely useful. And our audits indicated that when you do a dual subsartorial plexus block in a total knee replacement, it becomes an effective component of postoperative multimodal analgesia. And here I would wanted to recommend, just because we used the dual subsartorial plexus block, it's not that we didn't give them other analgesia. So patient gets 4 gram paracetamol, 90 milligram of ketorolac, plus this block. and rescue will be opioids, because pain is carried through several different sources, and we need to give non-steroidal inflammatory drugs, and also we use dexamethasone in the preemptive analgesia, because every tissue injury produces pro-inflammatory release of substances, and this increase sensitizes the nociceptors. So 1 dose of dexamethasone, non-steroidal anti-inflammatory paracetamol IV given before the incision, there's a huge decrease in the postoperative pain. And I just wanted to tell you that procedure-specific multimodal analgesia have to come into play. For want of time, I don't want to go into the nitty-gritties of it, but this is the dual subsort block, and it's a 2 injection that we do. And the first injection, you see what we cover, and in the second injection, you see what we cover. And this is something, it covers the entire the nerve supply to the knee joint. And this is something has completely revolutionized our postoperative opioid requirements in major spine surgeries, including scoliosis surgery, and just depositing the drug between the transverse process and the erector spinae on either side has made a huge difference to our patient. Adjuvants, we use adjuvants and we do audits of our adjuvants. And I think the adjuvants which I would strongly recommend are, it is based on clear logic that the entire melting pot is the dorsal root ganglia. And here is where the pain gets accentuated or the pain can be inhibited. So the drugs that we have found to be effectively used and literature supports are, of course, that we do not know several facets, but we ask ourselves a question, are we doing good to our patient or not? I think adding adjuvant, I find it's extremely useful to the patient. And the drugs that we use are dexamethasone and dexmedetomidine. And how much dexamethasone? 4 milligram and 8 milligram, 2 different doses, even 6 milligram have been tried, found to be effective. How long in TKR it is effective? Close to 18 to 22 hours in our clinical audit. And definitely this is far more beneficial when you use and plan a single shot block. And dexmedetomidine, when we use at a dose of 1 microgram per kg along with the local anesthetic solution. And there are a lot of studies which says that you give a block and give either dexa and dexmedetomidine intravenously. Does it prolong the duration? Answer is yes, but perineural placement is far superior to intravenous drug. This is the take-home message I would wanted to give. And now we are moving towards, in the last few minutes, these are all articles from yesterday's American Society of Regional, latest article. So where is regional anesthesia moving forward? It is moving forward to structuring it to specific patient population and specific blocks for a specific population. So in this study, Australian New Zealand hip registry, it clearly indicates the outcome has been better in those patients with hip fractures who received on arrival block in the emergency room to decrease their pain, and then subsequently where there was a regional analgesic technique used in the immediate postoperative period. So this is the conclusion of the study. So it's clearly indicating the role of regional anesthesia in modern anesthetic practice. This study shows, now they compare bupivacaine and liposomal bupivacaine. It was always believed that liposomal bupivacaine is a wonder drug. It will increase the duration, but this study has negated it. It said, in this particular study published yesterday in American Society of Regional Anesthesia, it indicated that it did not prolong the duration of brachial plexus block. And the FDA has approved this liposomal bupivacaine to be used in interfacial plane blocks. And there are several studies which have shown that liposomal bupivacaine is very effective in interfacial plane block, but probably it is not very effective when it is placed in the perineural region. The reason being the rate of release of the local anesthetic from the liposome, the capsules may not be uniform. And that's why it could be not functioning the way it functions in the interfacial plane block. And this is again, I was telling that anterior QL is very good. And this article challenges this, and it says that it may not be very good. The reason I want to tell this is, Regional anesthesia is in the process of evolution, where each one of us have to contribute our outcomes. It's not like general anesthesia. General anesthesia, the learnings are over a century, but for regional anesthesia, it's only decades. So we need much more studies, larger RCTs, much more controlled trials to say where we are going. And there are several articles, but clearly proving the advantages of ultrasound guided block. This is an excellent article on a qualitative systematic review, and it concludes that it's excellent for anesthesia and analgesia. It seems to be the definite benefits on the large RCTs, fast onset of block with ultrasound, and reduced dose of local anesthetic, reduced dose of nerve injury. And now the AI and ultrasound for the beginners or those who are going to get new machines, there's going to be an artificial intelligence equipment incorporated within the ultrasound. So the minute you keep the probe, it will tell what are the structures there. Immediately it will come in. So you will know, oh, this is the subclavian artery. This is the subclavian vein. This is the anterior scalene muscle. So the minute you keep the probe, immediately the structures get labeled. This is because of the use of artificial intelligence, and I think this will make the blocks much more easy to perform. And it is also interesting that there are a lot of evaluation that is going on in training a person in regional anesthesia, educating a person in regional anesthesia, and something has emerged called as a global rating score. This is something phenomenal on structured teaching of regional anesthesia. And this is very important to know that these kind of studies are required about not the experience of a person, but it's the expertise of the person and the predictive validity of a human individual to do a block. So much of advancements are going on in how education has to be performed in using the ultrasound. And there are a lot of executive summaries which clearly show that we are moving towards safety with the use of ultrasound. And I know my time is coming to an end. So we need to be the change. And we shouldn't quote reasons that I don't have that, I don't have this, when I was not taught, I'm too senior to learn. I think it's not so. When we did this fellowship, the senior most person who came to learn for us with a 2-week was 74 years old. He came from a small village in Maharashtra to learn ultrasound guided block. He did not think I'm 74 years old and why should I learn? But the child in him made him come and learn. And I'm very happy to say that he's continuously now started using ultrasound machine. And it becomes important that as we grow in life, we need to earmark days to learn from the journals. And whenever you go to a meeting, it's just not the conference alone. Visit centers of excellence for one day to see the practices there. And in your lifetime, you need to say at least once in 2 or 3 years, you should go and attend an international conference to judge and gauge where they are and where we are. So it will give a future direction of how we need to take ourselves. And the last thing I want to say, don't equate anything to money, because many of my anesthesiologist friends with whom I studied, who are practicing in various parts of India, they say that if they give GA, they get more money. If they give spinal, they get less money. If they give block, they get much less money. And because of that, they don't want to give blocks. But after some time, I think money is not everything. Once your basic requirements have been met, I think you need to go to mastery of every single aspect that you could do for the benefit of the patient. And I would strongly recommend, if you're in the beginning phases, you should choose a block a week and learn a block. Get into the journals, many free articles are available, Google it, and watch a lot of procedures and videos. And in India, AORA is the torchbearer of learning in regional anesthesia. If interested, do become a member of that. And once you become senior, educate your junior and do an audit of every block that you perform, and you know at which level you are, accept failures and move forward. And when somebody talks about each one of us, it has to be, they have to think we are innovative, we are pretty unique, and we are very world class. The happiest people don't have the best of everything. They just make the best of everything they have. And I want to make each one of you, request you to make the best use of the infrastructure you have to give the best to your patient. Thank you so much for your patient hearing, and sincere thanks for the online anesthesia platform, Dr. Edward Johnson, sir, and Dr. Rajesh Jayaprakash, for giving me an opportunity to share my thoughts with all of you. Thank you so much.
Thank you very much, sir, for a wonderful presentation and throwing lights on the current practice of regional anesthesia. So he rightly said ultrasound is not the end of the tunnel. We have a long way to go. So with that, Rajesh sir, please.
Yes, sir. Sir, thank you, sir. Thank you very much for that excellent lecture, sir. We have some queries here. Sir, you talked about the learning, how to learn ultrasound guided regional anesthesia. So in your experience, what do you think is obstacle for this type of learning, and how to overcome this type of obstacles, especially for the beginners?
Sir, can I be absolutely truthful? The major obstacle, I would say, are the teachers. So because when the teacher does not know, he does not want to incorporate the particular practice into the system. This is what has been told by many teachers to me. That's number one. Number two, the ultrasound machine is not freely available. The department would have procured it, but many times they tell me it's under lock and key and it can be used only specifically. That's number two. Number three, I think in institutions where this has to be done, there should be an introductory session, as I said, with the blue phantoms. And needling is the biggest problem. Getting the sonoanatomy right, most of them get it right after some repeated scanning on volunteers. But then to push the needle towards the neural tissue and keep the probe there is very challenging. And this is one limitation. And for this, if they kind of do it in blue phantom, and in other institutions, they've also used the chicken breast and tissues from animal tissues. Like weekend, like Saturday afternoon when theaters are over, I think we can have sessions on needling. And these are things which will definitely aid. And that's why actually what I personally feel is if a country has to grow immensely, it has to be teach the teachers. Teach the teachers have to be there. And with that, I think all the obstacles will be removed. This is my frank opinion.
Thank you, sir.
Sir, you are rightly said, sir. Phantoms are most costly. So I train my postgraduates in the chicken leg ones. Yeah, that's a good way of doing it, sir. So phantom is about, as I said, it's about 90,000 rupees blue phantom. So, but also the thing is, it's one-time investment. But as you rightly said, sir, many institutions go for mutton pieces or chicken pieces, and they put the cap of the needle. That the cap is inserted into the tissue, and that becomes the target.
Sir, when we go for, as a beginner, when we go for buying the ultrasound machine, is there any specific recommendation which we have to look into? Because we are not radiologists or radiodiagnosticians, so we are sonologists. Is there any specific thing which you have to look into when you go for peripheral nerve block and other things?
Sir, number one, I think there are certain important factors, like there are machines which are available for cost is definitely everybody considers it. So there are machines which are available for 5 lakhs now. Many companies have come in, but the most important thing is the resolution of the image. The superficial image is very good, but when you want to do deeper blocks, it's not supporting. So what I would strongly recommend is if it's a one-time investment, to go for the best. And also it's very important that it has to be a very rugged machine. It has to take the wear and tear. And we need to invest on those machines in spite of being costly, which has got a rugged. And one of the most important thing is because this is one which is taken from one place to the other place, you need to go for imported stands, very nice imported stands on which the machine is mounted. So the wear and tear of the probe and the machine becomes very less. And also we need to choose on a company which will send a clinical specialist to stay with you for a few days until you become extremely good with the knobology and the know-how of the machine. So this is another important factor, and institutions can do this. And I would recommend this. And the fourth one is after-sales service. When you buy an equipment, you should choose a company where if you complain, for example, the companies which we use, if we complain, they come and immediately replace with one machine so that your clinical work doesn't suffer when this particular machine goes for a repair. I would consider several factors in the decision making of buying an equipment.
Sir, apart from the ultrasound, so what might be the future in imaging these nerves and doing a nerve block?
I think now, if you see, the future is towards going in for excellent imaging techniques. And now, for example, we have got probes with 24 megahertz up to 30 megahertz, where you will be able to see the nerve so clearly. And there are institutions, especially in onco-care, where they've gone for placing microcatheters between the fascicles for long-term care of cancer patients. If they have inoperable ones with severe pain, and microcatheters, and then you use this like 30 megahertz, where you can see the neural tissues well and place the microcatheters inside. That's number one. Number two, I think we also move towards educating, because if you see 90% of the world, still the anesthesiologists have not mastered ultrasound. So like when you drive a car, when you don't know a place, you will say that I want to go to Dr. Edward's house in Kanyakumari. You get the address and you feed it into your car. It says go left, turn, take right, and 3 kilometers, like that. The minute you keep the probe, now ultrasound machines have started coming with tutoring. It says that you need to say that I want to do a brachial block, and you place the probe in the supraclavicular region, and it will guide you. It will say when you insert the needle, number one, needle tracking, it will show the which direction it will go, and number two, it will say the structures are all labeled by the artificial intelligence, and it will say go little posterior, go little more medial, go little more. I think this is on the way. So which will make the performing a block much more easier. And the other important thing that is happening now is in altered anatomy, we are going for integrating ultrasound with MRI and CT reports. So the patient having a severe deformity of the spine, for example, and you got an MRI and CT done. So those images can be brought to the platform of the ultrasound. The ultrasound integrates the information got from MRI and the CT and the sonoanatomy that you are placing the probe. So all the three are integrated and informations are given to you on how to move forward. So this looks extremely exciting, and like other field, robotic has also come in. The robotics in ultrasound guided regional anesthesia. And also we now, I think the latest, I don't know whether you read the article, you just wear a spectacle. And this spectacle is the one where it is reflected from the machine, and you needn't see the machine there and give. The ergonomics goes off. You wear that ultrasound spectacle and you will be able to see the needle directly. So phenomenal advancement has been happening in the technology, and we are in for a very, very interesting period. But as of now, the biggest progress that we can make is every single anesthesia that we give should, irrespective of whether it is general anesthesia, spinal, epidural, a regional block to be given. And we need to make sure that a component of multimodal analgesia and make sure the VAS score is less than 3 the first 48 hours. I think this is the one which I think we should keep it as a target, and this should be the future. for every single patient who is undergoing anesthesia.
Regarding the local anesthetic systemic toxicity, we have multiple protocols, one from AORA, one from ASRA, and AAGBA guidelines also are there. So which one will be easy to follow? And
ideally, if you see, I would recommend all the three, because they are not based on large-scale studies. And the first guideline came from American Society of Regional Anesthesia, and Weinberg, who proposed it. I think it's pretty simple to follow one. And I think all the other are improvisation. Number one, I would keep it very simple. It should be available. Number two, you should know how to use it. All the three, one of the guidelines you can follow, end result will be the same. And at this point of time, I also would want to say it's a reversible cardiac event. And if it is not reversing with intralipid, you need to continue the CPR. And there are enough case reports to show these patients either are put on ECMO or they've gone for on bypass. And after a few hours, it's all reversed and the patient becomes awake. Reports are there. So unlike other cardiac event, here you continue to do an effective CPR. And meanwhile, if it's not amenable to intralipid, think of going on bypass.
Sir, in your adjuvant chart, you use the soda bicarb to see as an adjuvant. Do you use soda bicarb?
No, truly so. Not really. We use soda bicarb. And as I said, the literature, there are few literature which says this, but the problem is like it's not preformed. It's not available preformed. So when you add the soda bicarb, it can either become very alkaline and the PK of the drug may completely change. So I would not recommend in a day-to-day clinical practice in India, I would definitely not recommend using soda bicarb, because hastening the block can be achieved by placing the drug to the target rather than using soda bicarb. That's my opinion.
This is a personal question to you. Have you ever cancelled or delayed or postponed any case in this ultrasound era? Have you ever done to optimize the patient, take your own time to perform the block?
So this is a nice question. Number one is, if you're going to postpone a case, you also have to give the prescription of optimization. What I need to do, whether 6 hours is available, 12 hours is available, or 24 hours is available, what is that I'm going to intervene and make the patient better to undergo a particular procedure? That's number one. Number two, also look for avenues of trying to do the case even then, at that point of time, going in for more site-specific, procedure-specific anesthesia and analgesia. So, try your best, especially in trauma situations. You try your best to do the case at the earliest. If you want to postpone, give a prescription of what the interventions that you will do to make the patient fit. And try to do it at the earliest.
Sir, on liposomal bupivacaine, is it available in India? Or,
No, sir, it is not currently available in India. In fact, this is mainly produced by one company in New Jersey, Parsippany. And I had a chance to talk to the owner of this one recently in Greece. I requested him to come to India, but he said currently the drug is very costly, and they're currently marketing it only in US, Canada, and Europe. And they say if I have to come to Asia, I will have to go for a different strategy in reducing the cost, which at this point of time we won't be able to do. And he says the minute you come to Asia, the first thing they ask is, what is the MRP and what is to the hospital? All these things we do not know. We don't understand this language. So this is what exactly he said.
Thank you, sir. Edward, sir, that's it from the chat box. Sir, do you have any personal questions?
Yes, sir. Yes, sir. Thank you very much, sir. Thank you, Rajesh, sir. So it was a wonderful day in the history of online anesthesia. We had Bala Venkat, sir, and Archana on the online anesthesia. And Bala Venkat, sir, rightly said, it is regional anesthesia is going to be one part of multinodal analgesia, not analgesia, multinodal anesthesia. So you have to combine regional anesthesia, which is general anesthesia, in all feature anesthesia. So it is a multinodal anesthesia. Thank you very much, sir, for being for sharing your valuable time for online anesthesia and educated us. Thank you. Thank you, Archana. Thank you, Rajesh, sir. Thank you, viewers. So next week we are coming with an interesting topic on the transplant anesthesia. Thank you. Thank you, Ananda. At this juncture, I thank the sponsor Akrula, the A1 Logics, and also Anaesthesia TV. Thank you. We will meet next week.
Thank you very much, sir. Thank you.
Thank you, sir. Thank you.